Welcome to this update today. We'll be discussing the EV-301 update that was recently presented at ASCO 2022. My name is Dr. Nimira Alimohamed, and I'm a medical oncologist here in Calgary at the Tom Baker Cancer Center. These are my disclosures. What was presented at ASCO 2022 was long-term outcomes in EV-301, 24-month findings from the phase 3 trial of enfortumab vedotin versus chemotherapy in patients with previously treated advanced urothelial carcinoma. What we learned before this update was that long-term outcomes for patients with advanced urothelial carcinoma or metastatic bladder cancer were poor. Enfortumab vedotin is an antibody-drug conjugate directed against Nectin-4, and it demonstrated overall survival and progression-free survival benefits in patients with locally advanced or metastatic UC in the open-label confirmatory phase 3 study at the pre-specified interim analysis. So that initial data cutoff date was July 2020, and that was planned when 285 events had occurred. At the time of that data presentation, the median overall survival was around 12.9 months for enfortumab vedotin versus 9 months for patients who received chemotherapy. That hazard ratio was significant at 0.70. Progression-free survival also favored enfortumab vedotin at 5.6 months versus 3.7 months for chemotherapy. And as a reminder, these are patients who had previously been treated with first-line platinum-based chemotherapy followed by immunotherapy. So what we'll discuss today are the efficacy and safety data for EV compared with chemotherapy over a median follow-up period of approximately 2 years. The objective of this evaluation was to demonstrate long-term, sustained, and consistent efficacy and safety data for enfortumab vedotin versus chemotherapy. So as discussed, patients were eligible if they had previously received platinum-based chemotherapy and immunotherapy. Their performance status was ECOG 0 to 1. This pre-specified final OS analysis was planned when total events had occurred that were 439. The efficacy and safety findings had a cutoff date of July 30th, 2021. Patients on this study were randomized 1-to-1 to receive enfortumab vedotin, which is given intravenously on days 1, 8, and 15 of a 28-day cycle, versus pre-selected chemotherapy, and that included docetaxel, paclitaxel, or vinflunine, each given on day 1 of a 21-day cycle. As a reminder, the primary endpoint was overall survival. Secondary endpoints included progression-free survival, the disease control rate, overall response rate, and safety. Overall, 608 patients with locally advanced or metastatic urothelial carcinoma were randomized to enfortumab vedotin or chemotherapy. As of July 30th, 2021, a total of 444 deaths had occurred. With a median follow-up period of close to 24 months, median overall survival was prolonged by 4 months with EV compared to chemotherapy. That hazard ratio remains at 0.70. Consistent with the interim analysis, the overall survival benefit of EV was observed in the majority of pre-specified subgroups, as you can see here. Similarly, progression-free survival was improved with EV versus chemotherapy, and that was consistent with the previous data as well. So the hazard ratio was maintained close to what we saw initially at the interim analysis, now at 0.63. Patients who received enfortumab vedotin had median progression-free survival of 5.6 months compared to 3.7 months with chemotherapy. Notably, the response rate was higher in the EV group than the chemotherapy group. As you can see here, the confirmed overall response rate was 41% with EV compared to 19% for patients who received chemotherapy. The complete response rate with EV was 7% versus 3% with chemotherapy. The disease control rate for patients who received enfortumab vedotin was 72% compared to 53% for patients who received chemotherapy. As a reminder, this is third-line treatment. Let's take a look at safety. In the safety population, median durations of treatment were 5 months in the EV group and 3.4 months in the chemotherapy group. Notably, rates of treatment-related adverse events were unchanged from the interim analysis. As previously reported, rates of treatment-related adverse events were comparable between the treatment groups, and there were approximately 50% treatment-related adverse events that were grade 3 or higher in both groups. The treatment-related adverse events that were notable included decreased neutrophil count, decreased total white blood cell count, and anemia. Those were more common in the chemotherapy group. In the EV group, and rash, fatigue, and peripheral sensory neuropathy were more common. There were no additional treatment-related adverse events leading to death that were noted on this final analysis compared to the interim analysis. Since the interim analysis, 3 additional patients reported a treatment-related rash in the EV group. 2 were graded as a grade 2, and 1 patient had a grade 3 rash. No additional severe cutaneous adverse reactions were reported in either group. And the proportion of patients with other treatment-related adverse events of special interest were consistent with the primary analysis. So overall, there were no new safety signals identified. The authors of the study concluded that after a median follow-up period of approximately 2 years, enfortumab vedotin maintained a clinically meaningful and significant overall survival benefit versus chemotherapy in this patient population. And this was consistent with findings from the primary efficacy analysis. So to recall, progression-free survival and response rates were also consistent with those observed in the interim analysis. Safety and tolerability of EV and chemotherapy were consistent with previous findings as well, and no new safety signals were identified. This data showed the continued survival benefit of EV versus chemotherapy, including a sustained magnitude of benefit in patients with previously treated locally advanced or metastatic urothelial carcinoma. So in Canada, what does this translate to? We've been lucky to have access through patient support programs and special access programs. EV is Health Canada approved for use in this setting. So for patients who have progressed on first-line platinum-based chemotherapy, followed by immunotherapy, we do now have access through a patient support program, and most provinces are awaiting provincial funding. We've had patients on this treatment now for some time, and we can see that that benefit that we have seen in the phase 3 study has translated to a clinically meaningful benefit. Where are we moving in the future? So now we have treatment options showing an overall survival benefit in the metastatic setting, in the first line, second line, and third line settings. We now have patients who are living beyond that. We have patients who are getting to 4th and 5th line treatments. For patients who have FGFR mutations, we also have access to erdafitinib. We have studies ongoing with enfortumab vedotin and other lines of treatment, notably in the first line treatment setting, and we anticipate that we'll see some changes in our treatment algorithm in the near future. But to summarize, we have come a long way in terms of managing patients with metastatic urothelial carcinoma. To have an overall survival of over a year in the third line treatment setting is clinically significant and clinically meaningful for these patients. Thank you for your attention.